Welcome, everybody. So we're going to get started. My name is Amy Lundstone. I'm a registered nurse and project management manager with the California Bridge program. We're really excited for you to be here to help us kick off this first of the nurse training series, Innovations in Nursing, Transforming SUD Treatment in Your Hospital. This is the first of a 4-part series, so we're hoping that you'll join us for the continuing trainings in the future. We're going to launch a poll in just a moment to figure out who's on the call. And Caroline, could you go ahead and launch that for us? Great, so this is a quick poll to figure out who's on the call, which department you're in. For those of you who are just joining, please take a moment and say hello in the chat. Let us know where you're from. And while you're completing the poll, I'd like to introduce Ariana Campbell. She is one of the founding members and directors of the California Bridge program, works in the emergency department at Marshall Medical. Ariana, welcome.
Hi, I am so incredibly happy to be here and to see nurses and folks who are leading nurses on the call. This is definitely was sort of a dream in the making in engaging nurses across our state and really across the country in this work. I'm really eager to see what our polling results and to see who's here. I recognize Lindsay. Hi, Lindsay. All right, so we're going to talk about really the nurses' role in this project. So that I'm curious to see who's working where and what departments now. And oh, great, we have somebody from Barton here. Yay. That's a neighbor of mine. So I work at Marshall Medical Center, and I'm one of the directors, but I started a program 4 years ago. And I like to say I started a program without engaging my nurses, which is a huge mistake, which is why this is here. We know that nurses drive care, in emergency departments and hospitals. So incredibly important to make sure we make sure our nurses are on board and really driving this, especially in a lot of places where there's a lot of staff turnover, et cetera. Our nurses can really drive care. All right, so it looks like what we were hoping, 60% of our attendees are registered nurses, substance use navigators, 40%, and that's great because that's like a team approach. We have a physician and we have social worker. It looks like 60% work in the emergency department and 40% inpatient, and the majority do have substance use navigators in the hospital, which is really great. And if you don't know if you do, certainly we'll talk about how you can find out and how you can connect with your substance use navigator. All right, next slide. Right. I did want to introduce Tana. So Tana is our nurse advisor at California Bridge, but Tana and I have known each other for quite some time because she's a charge nurse in my emergency department at Marshall. And the way she came into this, actually, Tana, I made the mistake of starting this program without engaging our nurses. And I remember treating a patient who came through, and Tana came over to me when we were discharging the patient and said, "Oh my gosh, we just saved that person's life." And I said, "Yeah, we did." And she was really interested in the program. And I remember there was this turnaround because at first there was people who were coming in through triage and asking for treatment. And it was really kind of unclear, can we do that? What are we doing for this? And as soon as she saw what was going on, when folks would come in asking for treatment, she's like, "Oh my gosh, we can do that. And we're going to do this, this, and this." And really was very encouraging to our patients. And in a matter of time of engaging our nurses and getting a substance use navigator, we more than tripled the amount of patients we were able to treat. And a lot of that is, it's the first person you talk to is the triage nurse, right? So making sure our nurses are driving this, because I always say our triage nurses are the quarterbacks, right? Set the stage, set the tone for how the whole visit will go. So Tana really has taken a leadership role in this, both in our department, and she's leading this now as she's been a chair of our education department at Marshall and is really experienced in education and is just sort of a born leader. So I'm really excited that she is leading the charge in terms of our nursing program for California Bridge. And then Sherry Cisneros is also a nurse And her story, she actually took this on as one of the leaders at her hospital as a nurse. Hi, Sherry. And was able and became the substance use navigator. So she was a nurse and a substance use navigator. Really saw the difference in her hospital, and I'll let her speak to that a little bit more. And then wanted to take on a leadership role within California Bridge because she believed in this care so much. So we're very lucky to have Tana and Sherry, and then Amy Lund, who introduced this, is also a nurse. And also, it's sort of a breath of fresh air to be able to treat people who use drugs with evidence-based and really full treatment. And Amy, as a nurse, was able to identify that, and she came onto California Bridge and has been a part of it now for a couple of years and is a project manager. So we do have nursing representation within our organization, and we have amazing nurse leaders who are going to be able to take you through this talk. So Tana, I'll turn it over to you.
Thank you so much, Ariana. Next slide, please. All right. Thank you so much for joining us today. I am so excited to spend a little bit of time with you today. I just want to start by saying that Sherry and I both don't have any financial disclosures or conflicts of interest related to the content today. And then next slide. Let's look at our course objectives. So first, develop a foundational knowledge of the California Bridge program and its work. Second, evaluate how a healthcare provider's approach to substance use disorder treatment affects patient outcomes. And the last one is to implement evidence-based interventions into one's own practice that decrease stigma, discrimination, and moral injury related to substance use disorder treatment. And next slide. Thank you. So we are going to talk about a few things today. Sherry is going to talk about the first couple bullet points, and then I'll be closing. The first thing to discuss is just what the bridge model of care is. What is medication for addiction treatment if you are not familiar with it? We're going to talk about what a substance use navigator is, and then we're going to jump into talking about the culture of care and how we deliver healthcare, how that affects our patient perspective and how they receive care, so that we can try to create better access for care for patients who have substance use disorders. Let's see, we would really love for this to be as interactive as possible. So please share your thoughts, your reactions, your questions in the chat as we're going. We would really like to engage with you throughout this conversation. I know some of these topics may be familiar to you if you're already doing this work in your department, or it might be new to you. We probably have a wide range of attendees in the audience today. I do know that I wanted to share my story. Ariana touched on it briefly, but I still remember the day in the emergency department. I was covering our fast track area, and I was taking care of a patient, and all of a sudden I saw an order for buprenorphine in their chart, and I was like, what is this medication? I have no idea what this is. Like, what are we doing? So I went and talked to Ariana because she was the one who actually ordered it. And I was like, what is this? What are we doing? And she explained it to me, and it was absolutely incredible to watch this patient go from very miserable he was in opioid withdrawal, and he was suffering, obviously, and we gave him medication, and he walked out of our department feeling like a normal person. He was excited to follow up with outpatient care, and it was just a light bulb moment for me of like, oh my gosh, we can help these people get their quality of lives back. And that is just the coolest thing ever to be a part of. So wherever you may be, my hope is that today will at least prompt you to take a step back, evaluate your thoughts and your perspectives about people who use drugs, and hopefully you will take something meaningful away that will affect your practice in a positive manner. All right, so Sherry, will you jump into the bridge model of care for us?
Yes, I will jump in. Next slide, please. The California Bridge Model. Well, welcome everybody. And before I get started, for my nursing colleagues out there, I just really wanted to thank you. You're a hero every day on the front line, especially during this pandemic. And I know you are just doing everything. And I appreciate you, and I'm so grateful you're here. And I thank you, you healthcare heroes. So let's get started on California Bridge. What is the model? And it's pretty simple. For some of the hospitals that are already doing this, you know that it's rapid evidence-based treatment, connection to ongoing care, and a culture of respect. I'm gonna kind of touch over the first two, and Tana's gonna deep dive into culture of respect. We wanna just let everybody know that as of now, we have over 90 diverse hospitals have implemented this California Bridge model. We're very happy. Our goal is, you know, over 200 in the next 2 years by 2022. And, you know, with leaders like Ariana and Dr. Snyder and Dr. Herring, we just that is guiding us. You guys don't even know, Ariana is just, she's a rock star when it comes to MAT and helping people. And it's right here in our own state that we're having evidence-based treatment and doing really well. The next slide. So I wanted to go over our cumulative scores from since June 30, and this is not a very long time if you think that our bridge program, you know, has started, you know, recently. And I would say within the previous 2 years, we started this program, but these numbers are astounding. And it just, the research says it all. We've had almost 12,000 patients identified with OUD. Of those 12,000, almost 8,000 were provided with treatment. That is huge. The evidence is here. There's nothing more I can say about these numbers. We almost have given 6,000 prescriptions for MAT. That's our X-waiver program, and 5,000 patients linked to MAT care follow-up. And that is our substance use navigators. So these numbers are awesome, great. We can't wait to add to this number. However, there is a number I want to go back to, and that why it's important that I'm here helping Tana and Ariana and the Bridge team is we have 12,000 identified OUD, and we have almost 8,000 provided with treatment. That's approximately 4,000 patients we missed. Somehow they, you know, kind of went through the cracks here. That's where I implore our nursing staff. You guys are amazing, and I know when we nursing focuses on something, we get it done. And that's our number, that 4,000, that 4,000 plus patients that we can make a difference in their lives. So that's what I implore here. My plea is to help us identify and refer these patients. Next slide. So what is medication? MAT, it's just evidence-based treatment for substance use disorders with medications to prevent withdrawal, help control cravings, and increase compliance with treatment. So, you know, it's been tried and true. You've seen the previous slide. I kind of wanted to know, are we taking a poll, guys, for if they're familiar with MAT? Okay, if not, that's okay. We can move on. Okay, are you familiar with MAT, and are you familiar with buprenorphine? You know, when I started before this venture, I didn't even know how to pronounce buprenorphine. So it's okay. You know, like Tana said, she didn't know what it was. I didn't know how to pronounce it. You're among friends, guys. So be honest and just share. We kind of want to know if you just know the basics, and if not, because again, you're among friends and there's no judgment here. Like I said, I couldn't pronounce it. It took me a few tries. Not gonna lie, I love saying bupe, right? Is that what we all say about it, is bupe, rather than, and then give it out, the full name. Okay. So while we're waiting for that poll, has everybody got their numbers in? Okay, great. So you guys are, I like this, our numbers. Okay, so there's a few, one who doesn't. And so that's why I go over it, the simple stuff, right? So great, I'm glad everybody knows what it is. MAT, next slide. So as a nurse, we know evidence-based works in many, many areas. And I have the permission of my clinical champion where I used to work, Dr. James Kim. He's our ED medical director, and he made this slide, and I love when he explains this slide, and I hope I do him justice. He made this slide to compare the numbers for success. And there's an app for physicians, and they can go on and find out evidence-based practices and numbers needed to treat to save a life. And he put this in, and this kind of hit home to me as a nurse, because every day you guys are doing all of these, you know, aspirin and STEMI, right? That's an evidence-based, we have to do it. For physicians to give out 42 prescriptions for that aspirin, they need to give 42 to save one life. Those numbers are needed to save a life. For women in AFib, it's 25 prescriptions to prevent a stroke. Okay, 25 patients come to the ED, we're going to prevent one stroke. Steroids in COPD to prevent a respiratory failure, you need to treat 10 for that number of success. Defib, our code blues all over the hospital. We're wound up to 3 to save one life, right? We know out of 3 people that code, we're going to save one life out of those 3. Those were the number, evidence-based numbers show. But look at this number. If I was a betting person going to a casino, okay, I equate this to, if we give a buprenorphine prescription, an opioid use disorder, to 2 patients, they will retain, we only need 2 to retain in treatment. We have how many prescriptions that we gave from our previous slides? You guys, this is, you know, the math is here. You know, we don't have to work so hard. So we need to save that 4,000 link. You only have to identify 2 to make a difference in somebody's life. Next slide. How it works. What is our program in a nutshell? Person checks in to the ED and opioid withdrawal. A substance use navigator is consulted if you have one at your facility. Withdrawal is treated with a buprenorphine. Ex-waiver doctors are given a prescription. Your son does follow-up arrangements. And guess what? The person feels better and follows up because the treatment works, okay? So this is just the general overall what we're doing. Next slide. So what is a substance use navigator? I went to a conference, National Opioid Leadership Summit in December. And one of the key takeaways out of, you know, we're stuck in there for hours, but one thing that really hit home is the opioid epidemic will take more than one person and one profession. So although we have substance use navigators, they're a key component. Nursing cannot be overlooked because you are with the patients all the time. Sometimes they may tell you, you know, just a snippet of their life, but they come back, okay? Those patients are coming back for abdominal pain. Those patients are coming back for abscesses. That's why we need you to know your resource of a substance use navigator. They are vital. They're like your best friend, because when you don't have time, because I know you nurses you're taking care of the code blues, the STEMIs, the strokes, all of those that we talked about, right? But you have a reference and you have help for your patient. And it might not be the first time. That's the whole thing. We build relationships. That's what sons do. So you might want to say, you know, hey, this patient has been in here 3 or 4 times. They take opioids. Hand it off to your son and just say, you know what? I don't think they're ready for treatment, but you may want to just check in with them. Our sons are trained to approach patients with motivational interviewing and in a way that they do not offend. They are there to help and they build trusting relationships. So remember that, especially if you're busy. A lot of times, you guys, I know how busy and hectic it can be in the ER. And you know, you look at that patient, you look at the bed and say, oh, I just don't have time for this. Call your son. Okay, that's a tool in your pocket. You can just rip out and call, hey, I don't have time. This patient's kind of, you know, antsy and, you know, they want to leave and can you just come say hi? Okay, do it. You know, the worst thing that can happen is they decline to talk to the patient. But you know what? There's a connection. we'll leave a pamphlet, we'll leave a card. Okay, so always consider your substance use navigator on your team and willing to help. Next slide. What is a SUN? Okay, so I kind of went over that. They introduced the patients to the MAP program and services. They develop the connection and provide follow-up, and they change the culture by promoting harm. I'm not going to get into harm reduction. Tana's going to get into that later. But what I do want to explain is our SUNs are trained to talk to them and try to expel lots of information in a short amount of time, right? Because in the ED, we want to get it in and out. So it might not be the first time that they approach the patient. They might go up and an example, you know, they're not going to put you in harm's way either, but they're going to say, hey, your nurse cares about you and wanted me to come and meet you. You know, we do it in a non-judgment, no stigma. We do it in a really factual, honest way. I'm here to help. Your nurse wants to help. Your doctor wants to help. What's going on? You know, can you feel like talking? If here's my card, here's my number, call me. You know, I'm here all the time. SUNs are very resourceful. We also can text patients. Some have apps to text. They'll call in a week or 2 weeks. And sometimes we get special numbers for our patients, especially when they're admitting and registration. They give a fake number to all of the people that they don't want the number. A SUN can get sometimes a working number or how to reach them. So again, that's kind of a key in your pocket, right? That they might be able to extract crucial information to treat the patient. Next slide. So our workflow, just a reminder, the SUNs, you know, guides the patient throughout the whole emergency department, and most importantly, they follow up. So even, you know, I know our SUNs make bills really robust after hour procedures. So don't feel guilty. Oh my gosh, the SUN's not here. It's okay. All right. We will follow up, you know, but we need to identify these patients. We need to build that link for those 4,000 patients. We need an open line of communication. So it's okay. You know, the doctors know how to treat. They'll treat the patient. But initially, if we're here, we're going to come, we're going to talk about the program, perhaps give a packet, stay with the patient, because sometimes they're just afraid that they're going to stay in withdrawal. Okay. And that's something you guys don't have the time to, right? To say, hey, you're going to take the medicine. I'm going to sit and make sure you're okay. That speaks miles. Okay. Because they'll remember my nurse got somebody here to help me. Okay. The next is our SUNs are always going to consult with you and with the doctor. Okay. They're not going to do anything that's, you know, out of their scope. They are really going to work as a team. Remember my other slide, it takes everybody. It takes a healthcare team. And then they're going to facilitate. They're going to hear the success stories, or maybe not. Sometimes it's not a success story, but they're the ones that are going to follow up in 7 days, some SUNs a month later. I know during the pandemic, we kind of went through the list over and over again because our census went low too. So, you know, we're just calling back our patients. Hey, how's it going? So again, they build those relationships. Next slide. Making a difference in your ED. They can change everything in your ED. They can be a role model for the change in the ED. They can reduce stigma and biases. They can provide support to the ED. Remember, they are there for you. They network with community resources, and they may have resources that your social worker does not know. Okay, just going to put it out there. I've done a presentation with Ariana, and I love her story about there's this list that we give patients. Here's the list, right? And I love when she says that, because that hits home for a lot of people, especially nurses. We gave out the list too, right? And phone numbers don't even work on that list. So they may have a number or a resource that is not on any list, and they can connect immediately. It's not a here, you never know what happens to the patient. And they trusting relationships. Okay, that's what we can do. They have the time, because our nursing staff is doing everything else. They're saving lives, and that's where you guys need to be 100%. Real quickly, before I pass it on to Tana, I do want to talk about, just share a story. I have many stories, and I was going to talk about a 22-year-old student athlete, but I'm going to tell you just personally, there was a nurse who was using opioids and came to me and explained that it's prescription, they're not an addict, and they wanted help. And I share this story only because it comes full circle for nursing. Had we not had a program at my facility, this person wouldn't have felt kind of safe. You know, they did not know what to do. You know, our signs in the hallway, he kind of said, okay, I think I'm okay. Worried about his license, worried about all the repercussions of whether people were gonna, you know, treat him differently and fairly. Without going into too much detail, Tana has a lot on her plate to talk about and cover. This program, California Bridge, helped him get back on track. And I credit California Bridge. I don't credit myself, because our hospital would never have done this and helped somebody. So with that, you can change lives, and you don't know where it's going to come from. It could be a colleague, it could be a friend, it could be a neighbor, and your program is going to make a difference. And it starts, you know, nursing is vital and important to this. I've seen how that, with my different hats, you will always hear different, you have so many different roles. And this is one of the role, you know, that can change patients' lives. So just keep that in mind. I am here to help. If anybody has questions, you know, feel free to type them in the chat. I am with California Bridge, and you can reach me anytime. And with that, I'm going to pass it to Tana.
Thank you, Sherry. I appreciate that. Thank you for sharing that story as well. That's incredible. So thank you. All right, next slide, please. Perfect. All right, so now we are going to jump into talking about our culture in healthcare. And I think this is one of the areas that my practice changed the most with my site implementing this program. It really was a perspective shift, and I really have changed how I think about people who use drugs. Next slide, please. All right, so one of the most challenging aspects of this work, I think, is to really consider our culture of healthcare and frame how we think about people who use drugs. Our thoughts and our actions actually impact the way that we deliver healthcare, and that affects our patient perspective. And all of those small little interactions that we have with patients make up that actual culture of healthcare. Sometimes we have perspectives that are influenced by maybe peer influences, maybe past personal or professional experiences, past moral injuries. I know I myself, when I was a baby nurse, I was watching the nurses around me, I was watching my preceptor, I was watching other physicians and seeing how they interacted with patients and how they spoke about people who use drugs. And I basically modeled how I operated off of them, because I was new. I didn't know what healthcare culture was like. So I just kind of looked around and modeled how I interacted the same way that they did, right? And sometimes we don't stop and think about if that's right and impacting the care that we deliver. Next slide, please. All right, so I want us to reflect on that for a moment. I'm going to read you these 4 questions, and I want you to pick one of them and answer it in the chat if you are comfortable. So how do you think and speak about people who use drugs? Who or what experiences have influenced your perspective and view on substance use disorders? How do your actual values and beliefs agree with your actions? And consider the culture within the department that you currently practice. Are you adding to the current narrative, or are you being a change maker? I know I myself have wrestled with these questions, and there's no right or wrong answers. We're just wanting to share our thoughts here. So if you would pick one of those questions and answer it for me. All right. Let's move on here. It looks like we might be a little bit shy about sharing, and that's totally okay. Next slide, please. All right, so I have asked Ariana if she would share her story briefly. Thanks, Eric. Awesome. Maybe I just didn't wait long enough. All right,
So,
personal
yeah,
experiences. Excellent. Thank you for
and
sharing, everybody.
I'll share my personal experience now, just just to be transparent. So, why is nursing care in opioid use disorder specifically, or substance use disorders, important to me? So I have a personal experience. My sister really wrestled with methamphetamine. Actually, she had stimulant use disorder. For any of those folks who have had family members or personal history of substance use disorder, you know what this can look like. But unfortunately, my sister ended up, being admitted for a medical emergency to emergency department, and then ended up admitted to the ICU. And I'll never forget making that phone call to talk to the nurse. So what I did know is, in order for me to be effective in helping get my sister really good care, I needed to talk to the nurse. So but what I also knew is that the nurse was sitting looking at my sister, and I know what that looks like in the ED and in the hospital. I know that my sister had a history of drug use. I know that she was looking at her, that she looked a certain way. I know that there was judgment. And so I remember feeling very compelled to tell the nurse, hey, just so you know, my sister comes from a nice family. Like, my sister has a heart of gold. I remember having to vouch for my sister, and knowing that that would make a difference in her care. And where I've landed in all these years is, people shouldn't have to have their sister call and vouch for them, right? We should be treating folks just like they were a family member. And I'm sure other people have had the same experience. My sister ultimately died from the complications from her substance use disorder. And really where I landed is I wanted to change that stigma. I wanted to help nurses, PAs, physicians, registration, our techs, really have a different narrative for our patients who use drugs, and know that all of these folks come from families and have a story, and that it's really important to treat them well. I know that recently Tana was just nice to a patient who, had disclosed that she used drugs, and the patient cried because she said nobody in the medical profession had ever treated her with so much respect. And this patient, I really believe that in and of itself, of course, we treat with medications, we treat with evidence-based care, but just being nice saves lives. I absolutely believe that. So I just wanted to share that that's my own personal experience. And I know that the nurse did really treat my sister well, and she was transferred to a higher level of care. That conversation, I truly believe, did make a difference. So again, I think if we think of these folks that, our patients, they could be somebody, our family member, somebody else's family member. I say that all the time in my department. Yeah, that could be my sister. So.
Thank you so much, Ariana. I appreciate you sharing. All right, I have a few answers to our questions. I want to read a couple of those. So thank you so much, everyone who answered these questions. Lisa says, personal experience with family members helps me remember that this is a disease and not a weakness or a failure. And that is so true. That's something that we say often, is that addiction is not a moral failing. And so thank you for sharing that. That is so true. I use person first language. Yes. I understand people who use drugs and why they do. However, I'm learning more about how to destigmatize that in a hospital setting. Awesome. Thank you. Yep, that's what we're talking about today. So thank you. I used to care for drug-seeking patients before I understood how harmful that thought process was. So true, me too. Recently cared for patients with horrible wounds. It was difficult to start a process on starting them on methadone. In progress, awesome, yep. Goal is to be a change maker, thank you. Yep. All right, next slide, please. All right, so we're gonna talk about a case study real quick here. A 32-year-old male checks in through triage in a rural emergency department. He says, I've been hooked on pills ever since I injured my knee in college, and now I started using heroin. I'm dope sick and need help. The triage nurse sighs. She completes the triage note. She limits her interactions as much as possible. She writes in her note, patient is a heroin addict. He says he's in withdrawal. No signs or symptoms of withdrawal noted. She walks him back to an exam room and tells the primary nurse, I put a druggie in room 10. He just wants to get high. I don't even know why he's here. So we've all seen this, right? I mean, I know that I myself am guilty of similar interactions. I think that sometimes we forget to stop and take time to consider why we react or respond in situations in a particular manner. We just continue the status quo because that's kind of how it's always been, and we're busy, and that's just how it goes, right? Next slide, please. So I want you to take a moment and reflect on how you might handle this situation. Do you think you would have a similar or a different approach? How could this triage nurse handle the situation better? And most importantly, how might this patient feel about or approach future interactions with healthcare clinicians? So feel free to put it in the chat, or if you want to be unmuted and share how you feel about this case study, I would love to hear it. All right, so Amy says making judgment on patient needs without actually listening to the patient. So true. I think that we, especially as nurses, we learn our across the room assessments, or very, you know, we become very, very accomplished at making judgments or determining needs without necessarily stopping and listening, which is it's an asset in certain ways, but we also need to stop and consider when we need to stop and listen. All right, Kelsey says, I think acknowledging that the patient is here, thanking them for being here is a good place to start. Active listening, absolutely. Thank you. All right, next slide, please. All right, so we are going to talk a little bit more about the impact of healthcare providers. We all have a variety of influences and challenges that we are facing on a daily basis. Sometimes we've developed feelings of resentment or frustration. Maybe we have learned behaviors like I was talking about before. We've seen peers or colleagues interact in a certain manner. We've picked up language or word choices from them, and we just continue that without stopping to think about it. Or maybe we've sustained moral injuries in the past. Next slide, please. So let's talk about moral injury just a little bit more. If you're not familiar with it, moral injury describes the challenge of simultaneously knowing what care patients need, but being unable to provide it due to constraints that are beyond our control. And I want you to think about if you have a situation that is similar, because I'm going to ask you to share in a minute. So what this does is it causes us to have compassion fatigue, burnout. I mean, we talk about this in nursing all the time as nurse burnout, right? Maybe we have a lack of empathy. We feel powerless. And then sometimes that will cause us to have behaviors that are biased or stigmatized, or, you know, we lead with discrimination. And that's not really how we want our patients to feel, but sometimes we forget about that, I think. Next slide, please. All right, so what moral injuries have you sustained in the past? And have you ever been faced with a situation where you knew what care a patient needed, but you were unable to provide it? I know that I myself faced a situation just last week where we had a patient check into the emergency department, and he was someone who uses heroin somewhat frequently, and his girlfriend and he both got some Suboxone, and he decided, which is buprenorphine, and he decided to try it without really knowing much about the medication at all. So he went ahead and tried it, and what that did is caused a precipitated withdrawal. We're going to talk a lot more about the specifics of how to treat with buprenorphine, what it does, what type of medication it is. That all is going to be talked about in session 2. So if precipitated withdrawal is not a term that you know, come to session 2, we're going to talk about it. So anyway, he took the medication and then he felt absolutely terrible. He was in opioid withdrawal at that point. He didn't know why that was happening or what was happening. So he decided to take the naloxone that he had at home, and that just compounded it. So this poor patient, he showed up absolutely miserable. He was pale, cool, diaphoretic, curled up in a ball on the gurney. He didn't mean to cause this to happen, and he was just suffering. So I knew that there wasn't really anything really critical or urgent going on in the emergency department. So I went and spoke with the physician on duty, and I said, hey, this is what happened to this patient. What can we do to help him? Let's, he's suffering. And the doctor said, he's just gonna have to wait. And that's not what I wanted to hear, right? Like that makes, I think sometimes as nurses, we advocate for things, and sometimes we can feel powerless if that's not, we're not on the same page with the doctor, or, we're kind of sorting out what type of care that patient needs. And that didn't feel good to know that patient had to wait longer and suffer longer. Have you ever faced a situation like that? It doesn't have to relate to substance use disorder. And just so you know, that's not the norm in my department. That's not how it usually goes now. But unfortunately, sometimes that happens. Eric says often, Amy says not okay. I agree. Thank you. Anyone else? Does someone want to be unmuted and share?
Hi, Tana, it's Amy. I can just jump in real quick.
Yeah.
So I spent a lot of my bedside career in hospice, and moral injury is very real. To be helping a patient cope with whatever their current health status is, and listening to the stories that led to that point, and just seeing all these missed moments of healthcare providers spread too thin, of limitations with insurance, of all the other social determinants of health and factors that contribute to someone's well-being. And it's a very real wear and tear on the soul of a nurse who cares. And there's so many of us who care so deeply and want the best for our patients. And I'm really glad we're having the conversations about moral injuries, because it's a very good topic to address, because it's all part of the healthcare reality.
Yeah, thank you. Eric offered to share. Can we unmute him?
Yeah, I've been unmuted. Can you guys hear me?
Oh, good. Yes, Eric, go ahead.
Hi, just to introduce myself quickly. My name is Eric Hill. I'm a substance use navigator at Marshall Medical Center. And I think it's interesting. Have I ever came up against a situation where I thought the patient needed something and then they weren't able to get it? Yeah, that happens like every day, We operate in a system that we're like trying to change from inside of it. So it's like having those conversations are routine, where it's like, in the counseling field, we call that ambivalence, right? It's like the medical field is in this like area of ambivalence right now, where it's changing and adjusting, and people are learning and growing. So coming up against those conflicts are actually healthy growth points and education points to really spread this message of like low barrier treatment and working and recognizing those patient needs, like you talked about, meeting that patient where they're at. And Tana just does that. She models that in our hospital. And I think that's really productive for the rest of the staff to see that, not just the nurses, but everybody, because that's like promoting culture changes by exhibiting that behavior. But like, there are many times when the flow of the hospital just doesn't really meet the flow of somebody who needs help with like MAT or whatever that looks like, and that's where those types of adjustments and barriers come into play, where like if somebody's really, really sick, we can like maybe get them, a doc might be willing to give them Zofran prior to giving them something else, just to help with some nausea or whatever that looks like, and when there's things we can do in the meantime, and those are like really great growth points. And that's just what I like wanted to share. I think the barriers are there because of the system that we work in, and we're trying to change that every day that we go and do the work that we do. So thank you for doing the work that you do.
Thank you, Eric. I appreciate you sharing. That is so true, that we can use these difficult moments as a springboard to grow and change the culture in healthcare. And that's what we're talking about. So thank you. Next slide, please. All right, so we're going to look at this graph here. So you can see that all these peer influences we've been talking about, the moral injuries, past personal or professional experiences, those impact our thoughts and how we think about people. And then those thoughts actually impact our feelings. And like I said, those can lead to compassion fatigue, burnout, lack of empathy. And all of these compound to affect our actions. So maybe that causes us to lead with language or behaviors that are judgmental or biased. And what that does is it creates barriers to care. What they found when they looked at it is that patients with substance use disorders, they leave AMA about 3 times as often as patients who do not have substance use disorders. And that's not okay, right? We don't want patients leaving against medical advice when we have care that, you know, works and we can help these people, right? And when they asked the patients why they left AMA, it was often due to feeling isolated, stigmatized. Maybe they had incompletely treated withdrawal. So all of those reasons are why patients are leaving. So how do we change this narrative? How do we change from a healthcare culture that discriminates instead of welcomes and neglects instead of treats? How do we change that? So let's go to the next slide. We're going to talk about addressing stigma and discrimination. So I know that we as healthcare providers strive to give our patients the very, very best high quality care that we can offer. Sometimes despite our best intentions, we let experiences or personal beliefs or other things negatively affect our practice. So this is a really excellent opportunity to do a check-in and think about having some self-awareness and how do we combat these issues constructively. Next slide, please. So the first that I think was very impactful for me is just recognizing my own bias. Amy shared this quote with me the other day and it really resonated with me, so I wanted to share it today. The first thought that goes through your mind is what you have been conditioned to think, and what you think next defines who you are. So how do we become aware of our own biases so that we can, instead of, you know, springboarding off that first thought, intentionally choose to have that next thought and define how we want to think about people. Next slide. All right, use person first language. So if you notice, the terms to use focus on a person first, and the terms not to use identify those people by their behavior. So find ways to utilize terms that recognize that person first and value them as a person. So person who uses drugs, person with an opioid use disorder, rather than using terms like addict or user, junkie, drug seeker. I know I've been guilty of that in the past before I understood how I was actually impacting care. Next slide, please. The next one is to be intentional. Be intentional with your words, be intentional with your actions and your interactions, and be intentional with your personal growth and learning. Next slide. Normalize care. So we know that best practice for treating substance use disorders is to treat them like a medical condition, like any other chronic disease. First, we treat emergencies or crisis promptly. We also expect periods of relapse and recovery. And we also know that some clients are more apt to follow treatment plans than others, and we still treat them when they seek care. So I know that the person that comes to mind is that we have a type 1 diabetic in our community that comes in several times a month, borderline DKA, and they don't really manage their blood sugars very well at home. And it's frustrating, right? It's frustrating to us. We wish that they could manage it a little bit better at home so that they were a little bit more stable, but we still treat them when they come in crisis, right? This person still gets admitted to the ICU on an insulin drip when they come in DKA. And substance use disorders should be treated the same, just like all our other chronic diseases. Next slide. All right, so we are going to touch on harm reduction just a little bit here, but I do want you to know that for our session 3 of our nursing innovation series, we're going to do a really deep dive into harm reduction principles. So harm reduction is a set of practical strategies and ideas, and it is aimed at reducing the negative consequences associated with drug use. It's also a movement for social justice that's built on a belief in and a respect for the rights of people who use drugs. So I want you to think of some practical examples of what harm reduction is and put it in the chat. So how could this actually look like what could this actually look like in the hospital or wherever you work? What are some harm reduction principles? All right, Eric says needle exchange. Yes. What else? Safe use education. Yeah, absolutely. Narcan prescription and how to use. Acceptance. Yes. Acceptance is a really important piece, right? When patients feel safe and valued, they feel like they can access care, and that's important. So I'm piggybacking on that Narcan prescription. How about Narcan or naloxone distribution? I know from our department, we actually hand it to patients, so they go with it. Never use alone. Yep. Excellent. Encourage patients to keep returning, and it's okay if they fail. Yes. So important. No judgment. Scheduled follow-ups. Information on how to access care. Perfect. All right, thank you. Next slide, please. All right, so I want you to stop and think about all of these actions that I have brought up, and I want you to think about what specific actions you can take to address stigma and discrimination in your own practice. And it could be one that I brought up, or it could be something else that you've thought of. Either way, just think of something that you think you can actually put into practice. I know I myself am working constantly on language choices and figuring out how to use words that don't stigmatize, and also have it come to mind a little bit more quickly and have it be a little more natural, because sometimes I'm like, I fall back, or I'm like, wait, is that the right term? And so I'm kind of working on that one. Increase naloxone distribution to postpartum women with substance use disorder. Excellent. Thank you, Kelsey. That is an awesome thing to be working on. Eric says, heck yeah, agreed. All right, next slide, please. All right, so putting it all together. So this is the positive counterpart to the other diagram that we looked at earlier. So if we implement all of these actions like harm reduction, person first language, and offering treatment, we create a culture that is welcoming and non-discriminatory and non-stigmatizing. And what that does for the patient perspective is that they feel safety and respect and value. And what that does is creates access. And that's the whole goal here, right? Is we want to get patients access to evidence-based treatment because we have medications that actually work. And so how do we get them access to it? There's such great stigma and discrimination that is faced by people who use drugs. And we, as healthcare providers and nurses specifically, have a really unique opportunity and a responsibility to address this inequality with intentionality. So let's be intentional about it, okay? And next slide. All right, be the change and take action. So I want you to think about one new action that you will take to support a culture of care for people who use drugs. If you're willing, put it in the chat so we can all be encouraged and inspired by it. And then after that, we're going to open it up for questions before we close. While you're thinking about that one action, I just want to make sure that you know we have more nursing innovation sessions coming up. And the next one is specifically about how to start patients on buprenorphine and what nursing interventions, nursing monitoring is required and what that looks like. All right, Amy says, post examples of correct language in charting rooms or break rooms. That's a great idea. I know that my hospital puts flyers that they want people to look at on the door of the bathroom so that people look at it when they're in there. All right, provide nursing staff with resources on how to manage patients with substance use practices, best practices. Thank you, Nicole. Agreed. We have several handouts for nurses if you want something that's already ready to go on our webpage. So feel free to go find those and print them out. Create dot phrases with person first language and destigmatizing language. Yes, that's a good one, Eric. Thank you. Share language choices. Yes. All right, next slide, please. Does anyone have any questions? I know this is a kind of heavy topic. While you're thinking about that, feel free to put your questions in the chat. I know that I spoke with a patient the other day and it was the coolest thing ever. I was just talking with him for a minute. He had struggled with drinking alcohol and using opioids. And I spoke to him for a few minutes and he said, I've been trying for years and years and years to stop using, and I have been successful the last 4 years because of this program here. And I'm on buprenorphine and it works for me. And this program saved my life. And that was the coolest. That is just the coolest thing to hear, is that a patient sees that this is saving lives. Because we can see that on the scientific side, we can see that this does save lives, but having the patient see that too is super cool. So would sharing this video with some nurses at our hospital as a substance use navigator be an appropriate suggestion as I get to know some of them? Sure.
Aslan, I think that's a fantastic approach, is getting to know your nurses, figuring out who's who on the unit and how to help educate them and bring them into this shifting culture of care. We put a few handout links in the chat and it'll be included in the follow-up email, but there's a lot of resources for you and for everyone else who's working on shifting this approach to substance use care in their hospital.
I also want to offer and make sure you know that I'm always available to you. If you have questions that come to mind later or things you're thinking about, please feel free to reach out to me. My email and contact information is on the webpage. I'm sure it will be included in the links that you get in the post email. So please feel free to reach out. I'm always happy to chat.
Thank you so much, Tana. We're nearing 11 o'clock, so we're at time. Caroline, if you could click us on to our next slide. There we go. So here's our sign up information for the second session, best practices in nursing management, opioid use disorder, and acute withdrawal. So this will focus a little bit more on identification and assessment and appropriate nursing management, and a little bit more on the pharmacology of buprenorphine. It's a good tool to have. And then we'll have 2 other sessions a little bit later in the year, one about harm reduction and one where we'll explore the lessons learned. And we hope that you'll all join us for that. And maybe some of you would be interested in joining the panel and sharing some of your experiences. Next slide, please. And here's how to join us. Our website, cabridge.org, and you can sign up there for our mailing list. You can also follow us on social with @bridge2tx. We're really glad you were able to join us today, and we look forward to connecting with you more. Next slide, please. And here's how to get a hold of Tana and Sherry. As Tana mentioned, she's available. We're interested and accessible to offer TA to nurses. That could be a one-on-one call. That could be, right now a virtual session. We'll see if in-person becomes an option sometime in the near future, but we really want you all to be successful and be successful in transforming care in your community, in your hospital setting. So thank you all so much for joining us. For those of you who are interested in CME or CE, we will have a survey link that goes out a little bit later in the follow-up email, as well as links to the materials that we've referenced and a copy of the slide deck. So thank you so much for joining. And Nicole, yeah, we are the appointed champion. We're here to help you. So glad that you were able to join and we can keep us going. A big thanks to Tana, Sherry, and Ariana for being part of this today and joining all of us in this forward momentum. So we'll hang on for a second if there's a couple other questions, but we'll see you at the next one. Thanks for coming.
Thank you.
Thanks, Lisa. Glad you could join us. Nicole, go ahead. Do you want to unmute?
Go ahead. Thank you, Sky.
Nicole, are you able to unmute, or do you want to put your chat question in the chat? Don't have a mic. Okay, well, we'll hang while you type. And I, just in this moment while we're waiting to see if any future questions pop up, for those of you that are still with us, really want to acknowledge what Tana said about this being a little bit of a heavier topic, to explore what drives us and what fuels us, while also seeing that that might be a little different than the culture in the community. So I really want to applaud how you all are doing this work. And it might feel uncomfortable and crunchy in the moment, but it's all for the greater good.
Mm-hmm. All right, currently I'm a point person. How do I get the most engagement from my nursing and admin team? That is an excellent question. I think that one thing to be aware of is that it takes time, and it takes time to build relationships, but you being engaged and being accessible, being visible to people, I think that you will probably find those frontline leaders. As you get to know people, there's going to be certain nurses, if you talk to them about what you're doing, there will be nurses that are like, that is so cool what you're doing. I have a family member who struggled with this, or they might have their own story and they'll resonate with it, and find those people and get them talking about it. That's kind of how things have happened in my department, and it's really cool to see that change happen. Like, I learned about it from Ariana, and now I make sure all of our staff know. And so you need to find those nurses that are going to help you and engage with you. I hope that's helpful. Making MAT leaders is a great idea. Thank you.
We call them champions.
I try to make all my nurses champions.
And may I add, just Nicole, the best thing is to make rounds, daily rounds with your team, everybody from the doctors to social worker, just making a daily round and attending some of their shift huddles, asking the nursing director, can I attend a shift huddle? Can I just, get my flyer out? Just spreading the word. That's really important, because once they see you there, guaranteed you'll find some champions, you'll find some people that really want to help, and will start referring. Agreed.
Yeah, I would print out that handout. There's a quick start for nurses handout, and come prepared, come with that, and you can hand it to all the nurses. Most nursing departments, when the new shift comes on, they all meet in the same room. You can hand it to people and tell them what you're doing real quick, ask for a real quick minute, and do that multiple days, because you're going to catch different nurses on different shifts.
Mm-hmm. Exactly. And to echo that, the handouts that we've created, there's currently 3 of them. They're designed to be printed on a single piece of paper, front and back, to be shared in exactly that way, or during in-services, or laminated and put at the nurse's station. The goal is to have them really be a useful, accessible tool that can be helpful in the moment. So
yeah, one more thing I was going to say is give feedback. If something goes well, let the nurse know, hey, that patient that you talked to the other day went to their follow-up appointment and is doing great. Feedback is really important.
Mm-hmm.
Yeah, absolutely.
Perfect. I made a war board in the back hall for updates. That's awesome.
All right. Well, we're about 6 minutes past. Again, thank you so much for joining, and there'll be a follow-up email. And Nicole, please feel free to reach out directly. We're happy to chat. So thank you guys all for joining, and we'll see you at the next one.